Okay, good evening to all. Welcome to Global Academy of Medical Education. In this session, let us learn about the high yield pharmacology topics that can be expected in your FMGE examination. Myself, Dr. Padmanabha, TS, Faculty of Pharmacology at Global Academy of Medical Education. So first of all, we'll learn about some of the basic thing that you need to remember. So the basic thing what you should remember is which route has got 100% bioavailability. Please remember which route has got 100% bioavailability, that is your intravenous route. And also you should remember that, please remember, this has been asked many times in your examination, and also through oral route the first pass metabolism is high. So the oral route has got the high first pass metabolism. And also you should remember that whenever you give a drug through sublingual route, it bypasses first pass metabolism, as the drug will be absorbed through the lingual vessels and it will be entering into the systemic circulation through the lingual vessels. It will be reaching the systemic circulation. So sublingual route bypasses the first pass metabolism, as well as it has got quick action when compared to the oral route. And also you should remember that, so through IV route there is no absorption. So absorption will not take place through IV route, since you are giving the injection directly into the circulation, directly into the veins. And also please remember that when compared to the oral versus the rectal route with respect to the first pass metabolism, so which route will have a little bit higher first pass metabolism and the bioavailability? So the oral route has got more first pass metabolism when compared to the rectal route, which has got lesser first pass metabolism. And also, what will be the bioavailability here? Bioavailability will be decreased with respect to the oral route, whereas with respect to the rectal route, the bioavailability will be better when compared to the oral route. And also one should remember that whenever you give a injection through the IM route, so usually you prefer the oily preparation. So depot injections are preferred. Only the oily substances can be administered. So apart from that, one more question that you can expect is, whenever you give the drug through subcutaneous route, the irritant drugs are avoided. The irritant drugs are avoided. What is the reason for avoiding irritant drugs? Because subcutaneous space has got they have got rich in nerve supply. They are rich in nerve supply. So basically, whenever you give a drug through subcutaneous route, if you give irritant drugs, it will cause lot of irritation. So to decrease the irritation, you need to give a drug which are not irritant in nature. So the reason for the subcutaneous route being irritant for the some of the irritant drugs are because they are rich in nerve supply. they are rich in nerve supply. So these are some of the things you need to remember with respect to the routes of administration. And also, oh, and next we'll move on to the some of the topics. So sublingual route has got first pass metabolism. It is true or false? Actually, the sublingual route will going to be bypassed. Will be bypassed with respect to the sublingual route. So sublingual route will not have a first pass metabolism. The statement is false. So sublingual route will be bypassing the first pass metabolism, and the route with first pass metabolism will be oral route. It will be the maximum, as we discussed in the earlier slide. And when compared to the oral route and rectal route, the first pass metabolism, there will be partial first pass metabolism with respect to the rectal route, and bioavailability here it is completely reduced, whereas bioavailability with respect to the rectal route is slightly, it is better when compared to the oral route. And the route which has got 100% bioavailability is, please remember always, it is intravenous route. The route which has got 100% bioavailability is intravenous route, as you are injecting the drug directly into the systemic circulation. So there is no process of absorption involved. So there is no absorption with respect to the intravenous route. So next, coming to the route through which the insulin is given. So please remember, it has been asked many times, the common route through which insulin is administered is subcutaneous route. It is subcutaneous route. So you may ask one more question. So there are some insulin preparations where it has to be administered through intravenous route. So usually whenever you give a insulin to a diabetic patient, the common route that has been followed will be the subcutaneous route. Whereas for the emergency conditions, you can go with the IV insulin preparations. That is, you're going to use the regular insulin. So regular insulin will be preferred through IV route in case of the diabetic ketoacidosis. And also, let us see, heparin is not absorbed due to its larger size, and it is highly ionized. So because of their larger, not absorbed due to the larger size, and it is highly ionized. So since it is acidic in nature, and this statement will be the true. And please remember, so lipid soluble drugs, so basically they get non-ionized. So when the lipid soluble drugs means they are available in the non-ionized form. So it is the non-ionized form or the lipid soluble drugs which can easily cross the membrane. So thereby you can increase the absorption. Whereas the water soluble drugs, water soluble drugs will be ionized form, and they do not cross the membrane, and there is a decrease in the absorption. So please remember, it is the lipid soluble form, that means they are in the non-ionized form, or the one which will be easily absorbed. Whereas the water soluble form, that means they exist in the ionized state, and this will not be absorbed, or absorption will be decreased. So can we give insulin orally? So please remember, insulin being a peptide, so protein, insulin cannot be given through oral route, as it will be digested by the stomach acid. So that's why the insulin is not given through oral route, as it will be degraded in the stomach. So weakly acidic drugs usually binds to which of the amino acid. So weakly acidic drug will bind to the albumin. Please remember it binds to the albumin. Whereas the weakly basic drug will going to bind to the alpha 1 acid glycoprotein. Alpha 1 acid glycoprotein. So this you need to remember. So how to remember this? Acidic and albumin. Acidic and albumin I should remember. So acidic and albumin. For the basic you have a alpha. Basic you have a alpha, or you can remember with basic GP. Basic GP. Weakly basic drug will bind to the alpha acid glycoprotein, whereas acidic drug will bind to the albumin. So next is which is the most common method of drug absorption. So the most common method through which the drug will be absorbed is the simple diffusion. Please remember, it is through the simple diffusion is the most common route through which the absorption will going to occur. So let us see morphine. So morphine is a weakly basic drug, and it will be absorbed in the stomach. So as we know, the morphine is a basic drug. So if the basic drug is subjected to the intestine, in the intestine you have a pH of alkaline pH. So what will happen to the pH of the drug and pH of the media are the same. So drug and this is the medium, that is the intestine. So thereby the pH of the drug and pH of the medium is same. So that means to say, if the drug exists in the similar pH, what will happen? They will form a non-ionized form. That means they exist in the lipid soluble forms, and this will be absorbed. Easily. So this is the concept behind morphine. So this is the true statement you should remember. So as you can see, what are the weak acidic drugs and the weak basic drugs? So let us understand. So we have a weak acidic drugs and we have a weak basic drugs. So usually the acidic drugs example will be we have aspirin, we have barbiturates, we have methotrexate, we have penicillins, etc. On the other hand, we have basic drugs like morphine, atropine, we have scopolamine, etc. So what is the one thing you did find when we are writing the basic drug? All these drugs, as you can see here, they are ending with INE. So in your exams, if they ask to select the basic drug from the following option, please remember the basic drugs usually end with the INE and INE. So the concept here you should remember is, so whenever the aspirin is given, as you know that aspirin is a weak acidic drug in the stomach, when it enters into the stomach, the acidic drug will be in the acidic medium. Since the stomach pH will be acidic in nature, pH will be acidic in nature, they exist in acidic medium, thereby they forms a non-ionized form which will be easily absorbed from the stomach. Whereas the morphine as we discussed, it ends with INE. As ends with INE, they belong to basic drug. So they get absorbed in the small intestine, because in the small intestine the pH will be the alkaline. So therefore the basic drug will be existing in the basic medium. So if the basic drug in the basic medium, they form a non-ionized form and they get easily absorbed. Is that clear? So basically what you remember is, if the drug to be in a non-ionized form, so what should be? The drug should exist in the same pH as that of the medium. If the acidic drug is given, they get absorbed in the acidic medium. If you give a weakly basic drug, the basic drug will be getting absorbed easily through the basic medium that is in the intestine. Is that clear? Okay, fine. Next, coming to the no drug is absorbed from the large intestine. No drug is absorbed from the large intestine. Whether this statement is the wrong or the correct statement. So please remember, this is the wrong statement, because as you can see, we give drug through rectal route in the form of rectal suppositories, as also in the form of drugs like diazepam. Rectal diazepam can be given in case of febrile seizures. Example is the rectal diazepam, which are given in the treatment of febrile seizures in case of children. So these drugs will be absorbed through the rectal route. So absorption will occur. So rectum will come under the intestine. So this statement is wrong. So which route has got the fastest route of absorption? Please again remember here, they are asking about your fastest rate of absorption. So now you cannot tell the answer as IV route, since IV route do not got absorption. So through IV route, the absorption will not takes place. Please remember, through the IV route, the absorption will not takes place at all. So whenever the question is asked in the form of which route has got fastest absorption, if the word absorption is there, then your answer will be the inhalational route. So since IV route has not got the absorption, because it directly enters into the systemic stream itself, and it has got no first pass metabolism, you should remember, and it has got 100% bioavailability. So 100% bioavailability is always seen with the intravenous route. This you should keep in mind. Next, coming to the rate of drug absorption. So please remember, whenever we write a graph, let us write a graph to understand this. So this is the graph. This will be your response, and this will be your time on the x-axis and the y-axis. So this will going to represent the Cmax, and this part will going to represent the Tmax, whereas this area is the one which is the area under the curve. Let's say this is the curve which is been for oral route. There can be curve which can exist for intravenous route also, and they may differ with respect to the area under the curve. So this is the area under the curve. So this will be your area under the curve. So what they are asking, the extent of absorption. So please remember, the area under the curve. So this area under the curve will going to tell you about the extent of absorption, extent of drug absorption. Whereas Tmax will tell you about the maximum concentration or the peak concentration of the drug that has been attained after administration. Tmax will tell you about the rate of absorption, rate of drug absorption. Is that clear? So let us write again. So area under the curve will represent the extent of drug absorption, whereas the Tmax will tell you about the rate of absorption, rate of drug absorption, whereas Cmax will tell you about the peak or the highest concentration that the drug reaches in the plasma concentration. concentration. So the rate of drug absorption will be given by Tmax, whereas the extent of absorption is given by area under the curve. So this concept you should remember, because this has been asked many times in your exams. So how do you calculate the area under the curve? To calculate the area under the curve, so area under the curve is useful in calculation of the bioavailability and also the extent of drug absorption. So basically area under the curve will give you about the what is the bioavailability of the given drug, So how to represent the bioavailability? Again, this is one of the very important question. So bioavailability means it is the fraction of drug that will be administered into the systemic circulation. So whenever you administer a drug, the fraction of drug that enters into the systemic circulation in an unchanged form, it is called as bioavailability. Is it clear? Bioavailability. So it is represented by area under the curve to the oral numerator, and area under the curve below is the denominator, that is IV. So area under the curve divided by area under the curve IV. So this will remain a constant. So this part will remain constant, area under the IV. This is the constant or the standard thing that will be taken. And if you want to measure for IM route, you are going to change it here, IM, subcutaneous, sublingual, etc. So the denominator will remain constant, whereas numerator will going to change. So bioavailability area under the curve oral divided by area under the curve for IV. So ED50 or EC50. What does ED50 or EC50 will tell you about? So this will be the ED50. If you take 50% of the response, it is the 50% of the population in which the drug will have a beneficial effect. So ED50 or effective concentration or effective dose, it is a measure of potency. Please remember, so ED, effective dose, is a measure of potency. It is a measure of potency. So next is the TI. So what is TI stands for? TI stands for the therapeutic index. So what does therapeutic index will tell you about? Therapeutic index will tell you about the safety of the drug. Please remember, it will give you the idea about the how safe is the medications. So it will tell you about the safety of the drug. So how to represent this? It is represented by TI equals to LD50 divided by ED50. LD50 divided by ED50. LD50 divided by ED50. So how to remember this in simple terms? Please remember. So how to draw a diagram for this therapeutic index? Let us draw a diagram. So this will be your response, and this will be your the dose. That is a log dose. So whenever you plot a diagram here, so suppose this is the drug administered. So this will be the one graph, and this will be your one graph. So if you take ED50 and the 50%, so if you plot a graph here, this is the minimal dose that is required to produce the effect, and this is the maximal tolerable dose. So basically, whenever you administer a drug has to be in this range. This is called as therapeutic range, or it also called as sometimes therapeutic window. So always the drug has to will be in this range for their beneficial effect. So even if the dose comes below this minimal dose, what happens? There will be suboptimal response. suboptimal response. The response will not be that much enough to get a benefit. So if the dose increases, what will happen? Toxicity occurs. So always try to administer a drug in this range, that is a therapeutic window, which is safer range. So this will be the ED50, and this will be the LD50. So how to calculate? T high is equal to LD50. It is the 50% of the population in which it produces the lethal effect. It is a lethal dose. So 50% means it is a lethal dose, means it is a dose at which 50% of the individual will have a side effects. Whereas effective dose 50 means, effective concentration 50 means it is a dose at which 50% of the individual will be having the effective or the beneficial responses. So how to remember this? Please remember the formula TILE. TILE will be the mnemonic that you need to remember. Is that clear? Fine. So that's what the log dose response curve you have seen here with respect to the therapeutic index. So what they can give is, they can give a diagram. This is the log dose and this will be your response, and they may ask what is this A and what is this B, and what is this C, and what is this range D, and what will happen if the doses decrease, that is E. So here what will be the A? A is your, according to the formula TILE, it is the lethal dose by effective dose. So A is the effective dose in 50% of the population. This will be the 50% response, and this will be your lethal dose 50. And what will be this? This is the therapeutic index or the therapeutic window, or the, you can call it as therapeutic range. That is the safer range of the drug. So what will happen to the D? D is the toxic dose. And E will be your suboptimal dose. Suboptimal dose. Is that clear? So that's what therapeutic index is a measure of safety. Please remember always, therapeutic index is a measure of safety. So why you need to know about the therapeutic index? Because the narrow therapeutic index will be less safer in nature. So always remember, if they give the weather statement like narrow therapeutic index can be used without any monitoring, that is false. Always the narrow therapeutic index drug requires a special monitoring, that is therapeutic drug monitoring has to be done frequently to avoid the side effects. So narrow therapeutic index is less safe because it has got more adverse effects. So if a small amount of the drug has been deviated from the therapeutic range, either it will create a suboptimal response, even a minute increase in the concentration will going to cause the increase in the toxic effect. So some of the examples are the digoxin, tricyclic antidepressants, and the lithium. So remember this, digoxin, tricyclic antidepressants, and the lithium has got the low therapeutic index. So we can call these are the drugs which cause low therapeutic index. So always which is preferred? The drugs having high therapeutic indexes are preferred. So drugs having high therapeutic indexes are preferred. Is that clear? Okay. So enzyme inducer decrease. Next is the concept is enzyme inducer decreases the metabolism of the other drug. So for example, you give a drug A. This will going to induce the, let us take this, these are the enzymes. enzymes. So what will happen to the drug B? If the drug B is getting metabolized by these enzymes, if you increase the concentration of the enzymes, what will happen to the concentration of the drug B? The concentration of the drug B will decrease. So the enzyme inducer decreases the metabolism of the other drug. So this is the false statement. So usually what will happen? Enzyme inducers will increase the metabolism, they increase the metabolism. So which metabolism is increased by drug A? The metabolism of drug B has been increased by drug A, because drug A is the microsomal enzyme inducer. So let us take an example among the anti-tubercular drug. So which is the enzyme inducer? Which is the famous enzyme inducer, which starts with the letter R? So that is your rifampicin. Rifampicin you need to remember. So rifampicin is a potent enzyme inducer. So let us take the one more concept. Generally they are going to ask regarding these microsomal enzyme inducers and inhibitors in the form of the case-based MCQs. So as you know that rifampicin is an enzyme inducer. If, for example, a 25-year-old female was on oral contraceptive pills, and suddenly you diagnose with the tuberculosis, and doctors will going to add the anti-TB medications. Following that 1 month later, what happens? The urine pregnancy test is positive. So what could be the reason? Since among the anti-tubercular drugs you have a rifampicin. As you know, rifampicin is a potent enzyme inducer. It would have induced the enzymes. This is the inducer, and this rifampicin would have increased the metabolism of OC pills. Thereby what happens to the concentration of OP pills? The concentration will decrease. So if the concentration of the OC pill decreases, what happens to the effectiveness? So its effectiveness will reduce. So there will be a oral contraceptive failure. So there will be contraceptive failure. Whether the statement is correct? Yes, this is the true statement. So let us understand with respect to the kinetic. Next is the concept on kinetic elimination. So with respect to the kinetics of elimination, let us understand this statement. So constant amount of drug is eliminated per unit of time is the which order kinetics. And one more definition is there. It sounds similar. Please do not hurry and tick the options. So please read the sentence carefully before opting the options. So there is a constant fraction of drug which is eliminated per unit of time, and it belongs to which order? Kinetics. That here the two key words to describe the first order and the zero order kinetic is the amount and the fraction. So if they are telling about the amount of drug, it is the amount of drug, you need to go with the zero order kinetics. Why? In the amount you have got O. O means 0. So constant amount of drug is eliminated per unit of time in case of the zero order kinetic. Whereas the constant fraction of the drug is eliminated. How you can remember? Fraction has got F for F. That means the first order kinetics. This is the first order kinetics. So let us make a statement. So if the kinetics of elimination, if you understand, if there is a amount is involved, constant amount of drug is eliminated, that means it follows the zero order kinetics. Whereas if the fraction of drug is eliminated, it will follow the first order kinetic. First order kinetic. Is that clear? Is that clear? Okay, next is the concept of the first order kinetic. So what will happen, for example, in a drug following first order kinetic? That means the fraction of drug is eliminated. Fraction of drug is eliminated when the dose of drug is doubled. What will be the off-life? What will be the off-life? So whenever you double the dose, the off-life will remain constant. So this you need to understand. So whatever the concentration you are administering, proportional to that there will be elimination. So then what happens to the off-life? Off-life will remain same. Even if you double the dose or the concentration, elimination will be increased. So there will be constant off-life will be available for the first order kinetic. So next is what will be the sentence called? A fraction of drug or the administered dose that reaches the systemic circulation in an unchanged form. So this is the definition for bioavailability. So again we'll revise which route has got 100% bioavailability. It is your intravenous route. So here let us understand the concept with respect to some of the findings. That is the first order kinetics. So in the first order kinetics, let us see what happens to the T-half. So what we did, even if you increase the concentration, see here, even if you increase the concentration, what will the proportion of elimination? The elimination will be proportional. So there is an increase in the rate of elimination. If you increase the dose, the elimination rate will increase. So that is why here you can see that. So T off will remain same in first order kinetic and clearance will remain same. For example, if we say that clearance is the 50%. So 50%. For example, initially you are given a 10 milligram, and if the elimination is 50% means 5 milligram. So if you increase the dose, 50 milligram will be eliminated. That is 50% of the drug will be eliminated. That is 10 milligram will be eliminated. There is a constant elimination is there. So what about the elimination rate? Elimination rate will be proportional to that of the dose what you are administering. So if you increase the dose, rate of elimination will increase, whereas the T off will remain same. The T off taken for this will be the same. So T off will remain same and clearance will be same, whereas elimination rate will increase in the first order kinetic. So what happens in case of the zero order kinetic? Zero order kinetics, as we remember, first order means it is a fraction. So when the 50 fraction is removed every time, whereas in case of the zero order, it is the amount. For example, let's say if you give a 10 milligram, let's say only 2 milligram is eliminated. So what will be the concentration afterwards? It will be 8 milligram. Even if you increase the dose to 20 milligram, so what will be the fraction of drug that is eliminated? That will be 2 milligram, constant amount. So what will the concentration which is left out in the plasma? That will be 18 milligram. So the chances of adverse drug reaction due to the increase in the dose will be seen with the zero order. With zero order, the adverse effects risk will be more. The risk of adverse effects will be more. Here, the T off will going to increase. To eliminate this, it takes more T off. Again, this will be eliminating 2 milligram. It will become 16. Then it will eliminate 2 milligram. It will become 14. It takes longer T off. So that's why T off will going to increase. And already plasma concentration has been increased already. Plasma concentration is increased. And what happens to the clearance? The clearance is inversely proportional to the plasma concentration. So if you increase the plasma concentration, clearance will decrease. Clearance will decrease. So that's why the plasma concentration increase, the clearance will reduce, but the elimination rate is constant. So here the elimination rate is 2 milligram, 2 milligram. So what is the example for zero order kinetic that you should remember? Zero order kinetics. So for the zero order kinetics, the famous mnemonic what you should remember is the watt power 0, watt power 0, watt power. So W stands for warfarin, A stands for aspirin, T stands for theophylline, and one more T stands for tolbutamide, and one more P stands for the phenytoin. So this thing you should remember. So always please remember, in the first order kinetic it is the constant fraction, F for F. In zero order you have got the O, amount you have got O. That is the zero order, it depends on the amount. The T off and the clearance is same in case of first order kinetics, whereas elimination rate is increased. Whereas the T off is increased in case of zero order kinetic, plasma concentration is increased, but the elimination will remain same, but the clearance will also decrease. Clearance will decrease. So here you can see that in the zero order kinetic, all the T of plasma concentration will be increasing, whereas the clearance will going to reduce, which are responsible for the toxic reactions. So this thing you need to remember. So this thing you need to remember for solving first order and zero order kinetics. So bioavailability, you should remember, bioavailability will depend on two factors. So what are the two factors on which bioavailability is dependent on? So bioavailability is dependent on two factors, that is, one is the absorption and another is the first pass metabolism. So if the absorption increases, what will happen to the bioavailability? Bioavailability will increase. So what happens if the first pass metabolism is increased? If the first pass metabolism increase, there will be decrease in the bioavailability. Is that right? Fine. So let us move on to some of the very important questions that has been already asked in your previous exams. That is, you need to choose some of the secondary messengers which are responsible for the drug functioning in the cellular as well as the organelles. So what we have under the second messenger is, so please remember these examples. We have a second messenger as cyclic AMP, we have cyclic GMP, we have a inositol triphosphate, diazyl glycerol, nitric oxide can act as a second messenger, even the calcium can act as a second messenger. And here, next coming to the poisoning. So already we have discussed, let us revise again, and we'll also find out which are the alkali drugs which can be added for treating the acidic poisoning, and what are the acidic agent which can be added to treat the basic drug poisonings. So here, see here, we have a aspirin. Aspirin is a acidic drug. So in case of acidic drug poisoning, so what you want to do is to eliminate the acidic content in the body. You need to alkalinize the urine. So what will happen once you alkalinize the urine? Here, what is the pH? Here the pH is acidic. So if you alkalinize the urine, what will happen to the pH? pH will be alkaline. So what is the concept what we discussed earlier? If the pH is same, if the pH of the drug and pH of the medium is same, there will be absorption. So if the pH is different, if the pH of drug is acidic and the pH of the medium is basic, the drug will exist in the ionized form. There will be increase in the ionized form which are not available for absorption. So this will be easily removed through the kidney through urine. So what are the agents which are used for alkalinizing the urine? So here is the key concept. So to alkalinize the urine, you use sodium bicarbonate, or you can use carbonic anhydrase inhibitor like acetazolamide. So to treat the aspirin poisoning, you will be using the sodium bicarbonate or the carbonic anhydrase inhibitor. So next, coming to the amphetamine poisoning. So as you can see here, the amphetamine is a basic drug. It is a basic drug. In case of basic poisoning, so what will the pH? Here the pH is alkaline. Alkaline. So if you want to acidify the urine, so once you acidify the urine, what will happen to the pH? The pH will be acidic. So there is a drug is basic and the medium is acidic. They are in the opposite pH. So the opposite pH means they will be in a ionized form, and this will be easily removed through urine. Which are the uh, substances that can be added to acidify the urine? So please remember, to acidify the urine, you need to give vitamin C or ascorbic acid, or you can go with the ammonium chloride. Ammonium chloride. Is that clear? Ammonium chloride. So this has been asked many times in your exams. Please remember, you can expect one question from this in your examination. So this is the key concept you should remember. So next, coming to the some ion channels. So there are many ion channels. The most of them will have a G protein coupled receptor activity. Apart from that, which are the drugs or the receptor through which they will going to act? So through in the form of ion channels, we have in the ion channels we have nicotinic receptors, we have GABA, we have glutamate. In glutamate we have two receptors, NMDA and AMPA. So we have nicotinic, we have GABA, we have glutamate, and the serotonin. So it is easy to remember. So remember, all the excitatory, all the inhibitory, they belong to ion channel. And we have a nicotine and the serotonin. In nicotine, what you have, you can remember here, you have a I. So it belongs to ion. Nicotine belongs to ion. Is it right? Serotonin. Even in the serotonin, you can remember. So if you write a serotonin, you have a I. So ion, it belongs to ion. So this one. So in the ion channel, in the drugs which are acting to the ion, they will utilize nicotinic receptor, since nicotine has got I, and you have serotonin receptor, you have got I, that is ion channel. Apart from that, both excitatory and inhibitory neurotransmitter will act through the ion channel. Then we have a drugs which can act through the tyrosine kinase. So we have an example such as the growth factor, insulin like growth factor 1 will act through the tyrosine kinase. This has been asked many times in your exams. So what are the things which will going to act through the JAK-STAT receptors? JAK-STAT. So we have a growth hormone. Please don't confuse. It is the growth factor which will act with the help of tyrosine kinase, whereas growth hormone will be acting with the help of the JAK-STAT. Then we have a prolactin growth hormone. We have the inflammatory mediators like the interleukins and the cytokines. And one more thing you should remember, very very important, is the nuclear receptors. Again, it is very important. So it can be divided into nucleus and the cytoplasm. Under the nucleus we have hormones. So which hormones? We have a thyroid hormones T3 and T4. We have a sex hormones, that is the estrogen, progesterone, even the testosterone, and we have a PPAR as well as vitamin A under nucleus receptors. If they specify about cytoplasmic, so you need to quote the examples of vitamin D as well as the corticosteroids, that is both the mineralocorticosteroids as well as the glucocorticosteroids are classified under the cytoplasmic receptors. So in the nuclear receptors, you can divide it into nucleus and the cytoplasm. Under nucleus you have a hormones and the sex hormones, that is hormones like thyroid hormone T3 T4. We have vitamin A and the estrogen, progesterone as well as PPAR. Whereas in the cytoplasm we have a vitamin D and the steroids, that is the mineralocorticoids and the glucocorticoids. Apart from that, one more very important question they are going to ask is the which will be acting in a form of slowest form and which will be the fastest form. So the receptor which has got slowest action, the receptor which has got the slowest action is the nuclear receptors, whereas the receptor through which the drug will be acting very fast is through the ion channel receptor. This you should remember. So nuclear, very difficult, it is very slow. Very fast is the ions will move very fast, so that's why the ion channels will have a fastest action. The nucleus will remain in the center, it takes some time to produce its action. Is that clear? Okay. So coming to the one more diagram, that is the Lineweaver-Burke plot. So this can be your potential MCQs in the upcoming exams. So what is this graph tells you about? So if you see this graph, so what you should understand is this part is the uninhibited. So this will be the uninhibited, that means this is the agonist. So this is the agonist. So x-axis will tell you about the Km, whereas y-axis will tell you about the Vmax, that is the concentration, the maximum concentration that can be attained. So Km will mainly tell you about the amount of drug that is required to produce the response. So if they plot this graph and if they tell that what is A and what is B. So here A is what? It is a competitive antagonist. So what is B? B is the non-competitive antagonist. So what is happening to the Km here? So if this plot, remember, if this plot moves towards this center, what will happen to the Km? Km will increase. Is it right? Km will increase. So what is happening here with respect to the competitive? It is moving towards the center. So Kmax should increase. The dose required to overcome the inhibition is more. You need to give the more drug to produce the similar response whenever it is blocked. So what happens to the Km with respect to non-competitive? So here the Km remains same. With respect to the non-competitive. Here it is same. That is unchanged. Same or unchanged. Whereas the one more thing is the Vmax. What will happen to the Vmax? So Vmax, remember again, if it moves towards the center, Vmax will be more. So here you can see in case of the competitive, the Vmax is crossing and it touches the similar point to that of the agonist in the y-axis. So that means Vmax is same here or it is unchanged with respect to the competitive antagonist. What happens to the Vmax of the non-competitive Vmax? Since it moving away from the center, the Vmax will be reduced. So how to plot this? So let us draw a diagram here. So when you plot this, okay, so let us say this is the drug, and if you, this is A, this is B, and this is C. Same thing, this is the log dose response curve, and this will be the response. Response will tell you about the Vmax, and here it is the dose. Dose, that is the potency. Potency. So whenever the B here is, can you identify this? To produce the same response, you are increasing the dose. You are increasing the dose. So this is called as competitive, sorry, this is called as competitive antagonism. Whereas this is the non-competitive. On the red is the non-competitive antagonism. So what is happening in case of the competitive antagonism? In case of competitive antagonism, the graph is shifting towards the right. So there will be rightward shift, and you need to increase the dose so that you can overcome the block. So what has happened here? So there is a similar, the efficacy is same, whereas the potency is decreased. So since it is moving away from the center here, means you are giving the larger dose, potency will decrease. So similarly, what happens with respect to the non-competitive antagonism? In case of non-competitive antagonism, there will be downward shift of the graph, downward shift. So there is a shift in the response. So what has happened to the efficacy? The efficacy has been reduced. So what has happened to the potency? Potency, it can remain same or unchanged. Even if you increase the dose also, what you get is the response is the lesser response. So in your exam, they can ask you to identify the graphs also. You should be thorough with this graph. Next is the teratogenic drugs. So let us understand some of the teratogenic effect. Teratogenic drug you need to remember from the exam point of view. So see here. So what are the teratogenic drugs? So these are the drugs which can cause some abnormality in the fetus when it is taken during the pregnancy through mother. So if there is a maternal intake, that effect will be seen in the fetus if the drugs are very teratogenic. So some of the teratogenic drugs you can identify here is we have a lithium, we have angiotensin converting enzyme inhibitors, ARBs, we have phenytoin, we have valproate, we have carbamazepine, and then we have carbimazole. So lithium, usually it causes Epstein anomaly. So please remember, lithium will cause Epstein's anomaly. So usually it is the defect of cardiovascular system. It will going to affect the tricuspid valve. So AC inhibitor, it can cause renal artery stenosis. So phenytoin can cause identoin syndrome. So basically it will have a cleft lip, it will have hypoplastic phalanges, and it can have microcephaly with respect to the phenytoin. Again, valproate is the most dangerous drug, most teratogenic drug. It is the most teratogenic drug which can lead to neural tube defects. Similarly, carbamazepine can also cause teratogenic effect, and carbimazole can also cause the teratogenic effect, like it can cause scalp defect if it is given in first trimester of pregnancy. So carbimazole is not preferred. If you want to, carbimazole is an anti-thyroid drug. It is an anti-thyroid drug. If you want to prefer an anti-thyroid drug, the preferred drug will be the preferred anti-thyroid drug in the first trimester will be your propylthiouracil. So here you can see that. So in first trimester, if you want to treat the hyperthyroidism, the drug of choice will be your propylthiouracil. And this you should need to remember. So among the antibacterial agent, so what are the drugs do you think which are safer in the pregnancy? So in case of the antibacterial drugs, the safer drugs will be your PCM. So what is PCM? PCM is your penicillin group of drugs, that is the beta-lactam group of drugs. You have cephalosporins, and the macrolides are the safest antibacterial agent in the pregnancy. Apart from that, there are other drugs which can cause the defect, which can cause the defects. So which can cause the defects. So which are the other drugs? Which are the other drugs? So you have aminoglycosides. Aminoglycosides can lead to ototoxicity and nephrotoxicity. Please remember, aminoglycosides can lead to ototoxicity and nephrotoxicity. Ototoxicity and nephrotoxicity. Whereas the fluoroquinolones will cause damage to the cartilage. It can cause tendinitis. It can cause a side effects such as cartilage damage as well as the tendinitis. It can cause tendinitis. What about the tetracyclines? Tetracyclines will going to cause a deformity in the teeth, as well as it will lead to bone damage, leading to retardation in the growth of the bone. Retardation in the growth of the bone. Very frequently asked MCQs which you should remember. So apart from that, next coming to the drugs related to the ANS. So very important drug here is the adrenaline. So please remember, as you know, adrenaline is a sympathomimetic drug. It is a sympathomimetic drug. Basically, it acts on the alpha receptors, alpha 1, alpha 2, alpha 2, beta 1, beta 2, as well as the beta 3. So adrenaline is a drug of choice for anaphylactic shock. If they ask about anaphylaxis also, the drug of choice will be the adrenaline. So what will be the concentration of the adrenaline which you are going to use? It is 1:1. The dose is 0.3 to 0.5 milligram. The route which is preferred is intramuscular. The most common site will be your vastus lateralis. So why do you not prefer to give through subcutaneous route? So already in shock, what happens? In case of shock, the subcutaneous blood vessels will be already vasoconstricted. So thereby, even if you give the drug, the action of the adrenaline will be little bit slower when compared to the intramuscular route. So can we give it through other routes? Yes, adrenaline can be given through other routes also. What you need to maintain is the dilution should be changed. So 1:10,000 dilution can be prepared, and you can inject it through intraosseous, intravenous, or endotracheal for the treatment of cardiac arrest as well as the anaphylactic shock. Why you need to dilute the adrenaline whenever you are giving through the intravenous or intraosseous or the endotracheal? The reason being, it will decrease the risk of arrhythmias. So if you use this dose in the form of IV route, there's an increased risk of arrhythmias. It can precipitate arrhythmias and it can lead to death. That's why the dilution has to be made before giving it through IV route. So even the dilution can be reduced further to 1:50,000 and the 1:50,000 to 1:20 lakh. So through whenever it is combined to the local anesthetic agent, example, so usually the adrenaline is combined with the lignocaine. So why means this adrenaline will going to prolong the action of the lignocaine. Is that clear? Okay. Next, coming to some of the very important treatment that is in case of the organophosphate compound poisoning. So here we have a organophosphate compound poisoning. So in case of the organophosphate poisoning, so basically it is an anti-choline esterases. So which type of anticholinesterase? It is a irreversible anticholinesterase. It is a irreversible anticholinesterase. It is a irreversible anticholinesterase. So what will be the drug of choice for the OP compound poisoning? Very frequently asked. So please remember, the drug of choice is your atropine, which is an anticholinergic agent which blocks the predominantly the M3 receptors. So you can give oximes. Oximes are given for what purpose? For the enzyme reactivation. So which enzyme reactivation it is? It reactivates acetylcholinesterases. So thereby you prevent the enzyme from aging. Is that clear? Okay. So drug of choice will be your atropine, and the drug which is used for enzyme reactivation, thereby you prevent the aging of the enzymes, it is your oxime, that is the pralidoxime, obidoxime, etc. So classical sign that you are going to see in case of the OP compound poisoning in the patient is they will have a pinpoint pupil. Pupil will be constricted. There will be reduction in the pupil size. So what are the other conditions where you're going to see the decrease in the pupil size? So you have drugs which will have a reduction in the pupil size, such as the opioid compound poisonings like morphine poisoning, etc. And in case of the carbamate poisoning. So please remember here, pinpoint pupil is seen with respect to the OP compound poisoning, opioid poisoning, and the carbamate poisoning. And please remember that whenever you administer atropine, so what will be the signs of atropinization? So in your exams they can ask what will be the signs of atropinization, or they will going to ask when to stop atropine. So usually atropine is stopped whenever you see the signs of atropinization. So the basic sign what you are going to see is, first feature is there will be pupil will be dilated. That means there will be mydriasis, and also there will be decrease in the salivation, decrease in the secretion. There will be retention of the urine. There will be difficulty in passing the urine. There will be difficulty in the defecation, etc. There will be tachycardia, etc. So how to treat the carbamate poisoning? So you have treated the OP compound poisoning. If the compound is carbamate, so what will you do in case of carbamate poisoning? So the drug of choice again will be your atropine. Why atropine? It is also a anticholinesterase. So you need to give a anticholinergic agent, that is the atropine. Whereas oximes are not useful in case of the carbamate. So if you take an example of diagram of the enzyme, so let us consider this is the carbamate poisoning, and this is your OP compound poisoning, and this is the angiotensin converting enzyme, acetylcholinesterases. So what happens whenever this compound comes, carbamate, this carbamate will going to bind. There are two sites. One is the ester site, and this is the ester site. This is the anionic site. So carbamate will bind to both ester site as well as the anionic site. Whereas in case of the OP compound, will bind only to the ester site, and this will be the vacant. To activate this enzyme, you will be giving the oximes. You will be giving the oximes, and enzymes will going to come and attach to this vacant site that is on the anionic side, whereas enzymes are not useful here because already the ester site as well as anionic site has been already occupied. Is that clear? Okay. So if the dose of the atropine is increased while treating, so how to treat the atropine overdose or atropine poisoning? Please remember the dose which will be the drug of choice for atropine poisoning will be your physostigmine. So next comes to the cobra bite. So in case of cobra bite, so the first thing you need to give is the anti-snake venom. Even in the option, if they give neostigmine, pyridostigmine, if you find the option as anti-snake venom, please go for anti-snake venom. Anti-snake venom is the primary or preferred drug. If and along with anti-snake venom, you can have the anticholinesterases, basically the neostigmine and the pyridostigmine, which basically reverses the muscle paralysis. So next comes the two important thing you should remember. The erection in case of the male will occur through parasympathetic system, whereas ejaculation is through the sympathetic system. Next, coming to the one of the important drug that can be asked in your exam, that is bethanocol. So bethanocol is a cholinergic agent. So basically where they are preferred, B for B. So it is mainly related with the bladder, B for B. So they are preferred in the atonic bladder. Bladder is already having no function, atonic, they are not functioning at all. To increase the contraction of the bladder so that there will be easy passage of the urine, you can use the bethanocol. Also in case of the condition like paralytic ileus, where there will be decreased movement in the intestine, for example following the any post-operative surgeries. And what happens to the lung? On the lung, it causes bronchoconstriction because they act on the M3 receptor here. So acting on M3 receptor, it causes bronchoconstriction. Here it acts on the M3 receptor in the bladder and the in the intestine to cause increase in the smooth muscle contraction. That leads to the movement. Okay. Next thing you should remember is the very important mirabegron. So mirabegron is a newer drug. It is a beta-3 agonist. So basically it will going to helpful in the treatment of overactive bladder. So what this mirabegron will do? So mirabegron is the beta-3 agonist. It will going to relax the bladder. So it is mainly used in the treatment of overactive bladder. So next comes, which is the drug that can be used for the treatment of orthostatic hypotension. So which is the drug which is preferred in case of the orthostatic hypotension? Please remember, in case of orthostatic hypotension, you will be selecting the drug that is alpha-1 agonist, that is the midodrine. Is that clear? Okay, fine. Next, moving on to the very important condition, that is myasthenia gravis. So in case of the myasthenia gravis, what you need to remember is very important, how myasthenia gravis diagnosis is done in comparison with the cholinergic crisis. So usually the drug which is used for differentiation of the cholinergic crisis and the myasthenia gravis is the edrophonium. So edrophonium is a short-acting anticholinesterases. The test which is done to differentiate the myasthenia gravis and cholinergic crisis, or it is also called as tensilon test. Why the edrophonium is chosen? Because edrophonium has got shorter acting. So what will be the treatment for myasthenia gravis? See, the treatment is you're going to use neostigmine. So if you have an option, you can choose neostigmine. The better drug will be the pyridostigmine because it has got longer acting and frequency of administration of the drug will also be less. So you're going to prefer the if you have both the options, that is neostigmine and the pyridostigmine. So what drug you're going to choose? You're going to choose the pyridostigmine is the better drug when compared to the neostigmine. The reason being, pyridostigmine is longer acting and it also very compliant with respect to the administration. So basically, again, neostigmine is also used for reversing the block which is produced by neuromuscular blockade. To reverse the neuromuscular blockade which is produced during the operations, so to reverse the blockade, to reverse the muscle relaxation, skeletal muscle relaxation, you can use the neostigmine which is going to increase the concentration of the acetylcholine, thereby it improves the muscle tone. So can we give aminoglycosides in the patient with the myasthenia gravis? The question is, can we give a myasthenia gravis in the, can we give aminoglycosides in the myasthenia gravis patient? So what happens if you give a aminoglycosides? So see here, if you give a aminoglycosides, what happens? This aminoglycosides will going to prevent the entry of calcium. So here you can see the aminoglycosides will prevent the entry of calcium. So what happens if there is a block in the entry of calcium? There will be no action potential, and the action potential will not be able to generate the action potential. Thereby the action potential will not reach the presynaptic junction. Thereby whatever the vesicles which contains the neurotransmitter will stay there itself. It will not be released into the synaptic cleft. So what happens if you block? There will be decrease in the calcium, and there will be prevention of calcium entry, and in turn it leads to decrease in the calcium release, decrease in the acetylcholine release. So thereby there is no action of acetylcholine on the NM receptors or the post-junctional receptors. NM receptors will be the post-junctional receptors, and there will be no contraction of the skeletal muscles. So it will basically, it will going to block the activity of the acetylcholine aminoglycosides. So in myasthenia gravis, already there is a weakness of the muscle, and already there will be a antibody which is produced against the NM receptors. So upon that, if you give aminoglycosides, there will be complete muscle relaxation, and patient will not be able to do his activity. So there will be complete relaxation of the muscles, which is not good for the myasthenia gravis patient. Next comes the tubocurarine. So what is tubocurarine? So as you can see here, the tubocurarine is a non-depolarizing skeletal muscle relaxant. That is a tubocurarine. So those actions, that is a relaxant action, can be blocked, or they can be reversed by giving the neostigmine, which is a anticholinesterase, which acts on the NM receptors. They can ask in your example, they can act on which receptors? NM receptors. So what is Sugammadex? Again, very important MCQ that you can expect. Sugammadex. Sugammadex is an antidote, specific antidote for treating the, or to reverse the actions which are produced by rocuronium and the vecuronium. Is that clear? They are the skeletal muscle relaxants. So we have a succinylcholine, which is a depolarizing skeletal muscle relaxant. So it produces phase 1 and phase 2. This phase 1 and phase 2 is not seen with the non-depolarizing skeletal muscle relaxants. So they are only seen with the succinylcholine. So the phase 1 blockade and phase 2 blockade. So what will happen if you give a neostigmine? What will happen? So neostigmine, please remember, as phase 1 is due to the persistent depolarization. So why persistent depolarization occurs? If there is an increase in the availability of acetylcholine, so this persistent depolarization will lead to muscle paralysis. So neostigmine will not be useful in reversing the phase 1 block. Whereas neostigmine is useful in the reversing the phase 2 block, because it acts similar to that of the non-depolarizing skeletal muscle relaxant. Is that clear? Okay. Next, coming to the mydriatics. So we have a passive mydriatic. Which is the passive mydriatic? So again, in your exams they can ask this question. So there can be mydriatics, that is dilatation of the pupil. So there is a passive mydriatics and the active mydriatics. Passive and the active mydriatics. So passive mydriatic example will be your atropine, and active mydriatic example will be your phenylephrine. So this is the M3 blocker, and this is the alpha-1 agonist. So passive mydriasis, let us find out which is the longer acting passive mydriatics and the shorter acting mydriatics. So longer acting mydriatics will be your atropine itself. Atropine will act for longer duration of time, or minimum it will act for 7 to 10 days. Whereas the shortest acting will be your tropicamide. Tropicamide will act for 4 to 6 hours. Tropicamide. So tropicamide is also a atropine derivative. Where do you use atropine? Atropine is mainly preferred for fundoscopy in children below 5 years, because their ciliary muscle tone is very high. Ciliary tone is very high. So you cannot use the atropine in case of adults. Adults, avoid in case of adults. What is the reason to avoid in case of adult? The reason being it produces vision, that is the blurring of vision. Blurring of vision, it can stay till 7 to 10 days, which is not acceptable. And also it can be used for treating the fungal corneal ulcers, where it will going to reduce the pain. Is that clear? And one more thing you should need to remember is you should not confuse with the tropicamide with the topiramate. Topiramate is the anti-epileptic drug. Anti-epileptic drug, they are also used as a prophylactic drug in the treatment of migraine also. Migraine. Is that right? And treatment of migraine, as well as M for M in case of maniac depressive illness, that is in case of bipolar disorders, you can use the topiramate as a prophylactic drug. There's one more drug that is called as enderine poisoning. That is the DTT. So in case of enderine poisoning, you need to treat the enderine poisoning symptomatically. So atropine will not be antidote for enderine poisoning. So next, coming to the graph which is produced by the adrenaline and the noradrenaline. So adrenaline will act on the receptors like the alpha 1, alpha 2, beta 1, beta 2 and beta 3, whereas noradrenaline will act predominantly on the alpha receptors. So thereby you can see noradrenaline, there will be increase in the systolic blood pressure, there will be increase in the diastolic blood pressure, put together there will be increase in the mean arterial pressure. So this can lead to increased heart rate, will lead to reflex bradycardia. So where do you use noradrenaline? Noradrenaline is preferred in the treatment of septic shock, cardiogenic shock, especially if they are associated with the hypotension. Is that clear? Okay. So what is the concept behind vasomotor reversal of Dale? So whenever you give a adrenaline, what happens? When you give a adrenaline, once you give a adrenaline, what happens? So there will be increase in the blood pressure, there will be decrease in the blood pressure. The increase in the systolic blood pressure and this diastolic blood pressure, this is mainly due to the alpha 1 activity and this is due to the beta 1 activity. So this is also called as biphasic response. So what happens if you give a alpha blocker? So if you give a alpha blocker and following the alpha blocker, if you give a adrenaline, so what will happen? This alpha activity will be lost and there will be exaggerated fall in the blood pressure. There is a decrease in the blood pressure. Exaggerated fall in the blood pressure due to the beta 2 activity. So beta has got vasodilatory action on the blood vessel. So this is called as vasomotor reversal of Dale. So next, coming to the dopamine. So again, with dopamine you need to remember the dose dependent actions of the dopamine. So what will the dose dependent actions of the dopamine? Let us understand. So please understand this, very important, very easy to remember. So dopamine, basically it has got three actions, dose dependent. At low dose it acts at 1 to 2 microgram per kg, moderate dose 1 to 2 and severe it is more than 10. So at low dose it acts on only the D1 receptor. D1 receptor is present in the blood vessels of the renal system, thereby it causes vasodilation. It causes vasodilation, which is responsible for decrease in blood pressure. And also, since there is a vasodilation, it will help in increasing the renal blood flow. At the moderate dose, it will act along with D1, it also acts on the beta 1 to produce increase in the force of contraction. It increases the heart rate and the contraction. At higher doses, it acts on along with D1, beta 1, it acts on alpha 1 receptor, it increases the BP. So to treat the cardiogenic shock, especially cardiogenic shock associated with the aliguria, you need to give a low to moderate dose. So only the low to moderate dose is preferred in case of the cardiogenic shock associated with aliguria, decreased urine. So to improve the urine production, you need to stimulate the D1 at the lower dose, thereby it increases the circulation to the renal system. So where do we use dobutamine? Dobutamine is used to increase the heart rate. So basically dobutamine, don't confuse. So the name is dobutamine, it acts on DOBA. B is there. So it is a beta 1 agonist. Beta 1 agonist only. Please remember, it is a beta 1 agonist only. Is that clear? It is a beta 1 agonist only. Next you have a tizanidine. So please remember again, tizanidine can be asked. Tizanidine is a alpha 2 agonist. Basically they are centrally acting skeletal muscle relaxants. So what are the other two alpha 2 agonists they and their uses? So we have a alpha 2 agonist like clonidine and methyl dopa. Very important. Please remember, clonidine and methyl dopa, they act at the presynaptic junction, and alpha 2 will cause decrease in the catecholamine release. Here, decrease in the catecholamine release, thereby decrease the blood pressure. Is that clear? Okay, fine. Next, moving on to the drug, that is latanoprost. Latanoprost is a prostaglandin analog. Which is the analog? This is prostaglandin F2 alpha analog. So what are the side effects of latanoprost? They can give a diagram and they can show these diagrams, like it can cause the side effects of iris pigmentation, and also there can be hyperchromia, that is called as hyperchromia iris, the pigmentation of the iris. There can be hypertrichosis, there can be macular edema, there can be growth of the eyelashes, there can be increase in the growth of the eyelashes, and there can be orbital fatty atrophy, which is seen with the latanoprost. And also one more thing you should remember is latanoprost is the first line drug in the treatment of open angle glaucoma. It is the first line drug in the treatment of open angle glaucoma. Let me ask a question. Which is the cholinergic agent that can be used in the treatment of open angle glaucoma? So cholinergic agent is your pilocarpine. So pilocarpine can be used, and please remember, pilocarpine, a special drug delivery system that can be used to treat open angle glaucoma, will be your AccuCert. You should remember. So next comes in case of the glaucoma, which group of drugs are totally contraindicated? So please remember, atropine or atropine derivatives, they are totally contraindicated in case of closed angle glaucoma, as it produces mydriasis. The angle will going to close. Once the pupil dilates, what will happen to the iridocorneal angle? This angle will be reduced, and there will be decreased outflow, thereby building up of the aqueous humor inside the eye, leading to the increased intraocular pressure that can lead to blindness also. So please remember, especially in case of the closed angle glaucoma, you need to avoid using the atropine. And what is the contraindication for inflammatory glaucoma? If there is a condition like inflammatory glaucoma, which drugs are avoided? So please remember, you need to avoid prostaglandin analogs to be avoided, because already you know that prostaglandin themselves, they are the inflammatory mediators. So in your exam they can ask which is the shortest acting beta blocker and the longest acting beta blocker. So what will be your response? The shortest acting will be your S-molol, S for short. So you can remember, short S-molol, short, S for S. So longer acting you have nodolol, So N comes at the end of the alphabetical order compared to E. So E is easier, so it is the shortest. N is the farther away alphabetical word, so you can remember it as it is the longest acting. Then you have a drug called as orlistat. So what is orlistat? Orlistat is a lipase inhibitor. So please remember, orlistat is a lipase inhibitor. One of the important side effects that has been asked previously is it causes steatorrhea. So next, coming to the very important slide, that is GLP-1 agonist. So GLP-1 agonists, they are used in the management of obesity. Please remember, which are the GLP-1 agonists which are used in the management of obesity. So GLP-1 agonists, they are also used as an anti-diabetic medications. So please remember, they are also used as the anti-diabetic medication. So which anti-diabetic medication, there can be question, which anti-diabetic medications are useful in the management of the obesity? Your answer will be your liraglutide and the semaglutide. Liraglutide and the semaglutide, they are the GLP-1 agonist. So what are the other drugs that can be used in the obesity? So the other drugs are, you have orlistat, that is the lipase inhibitor. There can be a antidepressants like the bupropion and naltrexone opioid antagonist. We have topiramate, we have phentermine, we have bupropion and the zonisamide. So basically you use the combination of the opioid antagonist, antidepressants and the anti-epileptics here. So please remember, the anti-diabetic drug that can be used for obesity is the GLP-1 agonist, that is liraglutide and semaglutide. Next, coming to the nicotinic partial agonist. So basically in your exams they can ask about the which are all the drugs that are used for the cessation of smoking cessation. So for treatment of the smoking cessation, so what you can use is the, here is the clear concept you can see here. See the we can use either the vernaclin, or you can use buprenorphine, or you can use the nicotine. So buprenorphine is the noradrenaline dopamine reuptake inhibitor. So among these are the smoking cessation agent. The most effective will be your vernaclin. So most effective will be your vernaclin. Vernaclin is the most effective drug. Next, coming to the prostaglandin. As we discussed, prostaglandin is contraindicated in the, please remember, prostaglandin is contraindicated in the inflammatory glaucoma because the prostaglandin itself is the inflammatory mediator. So what happens when you give that? It can lead to aqueous flares, as well as there can be a kerati precipitation in the anterior chamber. So this will be your one of the case vaginitis items. They will give on the administration of prostaglandin or on the administration of a drug, there was seen a aqueous, there was the aqueous flares and there was a kerati precipitation, and which of the following drug is responsible for this type of reactions? So basically it is a prostaglandin analog, that is latanoprost, bromatoprost, etc. So anti-glaucoma. So in case of anti-glaucoma, the contraindicated is the prostaglandin analogs. They are contraindicated in inflammatory glaucoma, as it can lead to increased, although it can lead to increased UVL outflow prostaglandin, and the prostaglandin analogs are the preferred drugs. That is latanoprost is the first line drug. So adverse effect is it can cause macular edema. So what is the effect on the cocaine with respect to the pupil? So what will happen when you give a cocaine? Now please remember here, whenever you give a cocaine will going to inhibit the reuptake of the noradrenaline, it will inhibit the reuptake of the noradrenaline, thereby it inhibits the reuptake. So what will happen to the concentration of noradrenaline? Noradrenaline will increase, since as we said noradrenaline has got predominant action on alpha. It will going to increase the blood pressure, it is going to increase the heart rate. As you know, on the iris you have got the two muscles. So iris you have got two muscles, one is circular fibers and one is the radial fibers. On the circular you have got the M3 receptors, and on the radial you have got the alpha 1. So stimulation of this will going to cause pupillary constriction, and stimulation of this will lead to pupillary dilation. So this is called as meiosis, and this is called as mydriasis, dilatation of the pupil. So cocaine will going to cause dilatation of the pupil. Is that right? Okay. Next, coming to some of the diuretic agent. So please remember, so what are there are some diuretic choices you should remember. So what are the diuretic choice in case of the pulmonary edema? Please remember, it is the furosemide, which is a high ceiling diuretic. That they are also called as loop diuretics. If you have a loop diuretic, you can choose the loop diuretics. So which is the drug of choice for cerebral edema due to head injury where there is an intraocular pressure? So the answer will be your mannitol. So next is the liver cirrhosis. In case of liver cirrhosis, edema, liver cirrhotic edema, you're going to choose the drug that is spironolactone. Spironolactone is a drug of choice for liver cirrhotic edema. So what is the drug of choice for acute mountain sickness? Please remember, it is acetazolamide. It is acetazolamide. For treating pulmonary edema, use furosemide. For treating the cerebral edema, use mannitol. To treating the liver-related side effect edema, you use spironolactone. And to treat the mountain sickness, you use acetazolamide. Acute mountain sickness, A for A, acetazolamide. For motion sickness, use iocin. Iocin is also called as scopolamine. Scopolamine. So usually, what you are going to use here, you are going to use the transdermal patches where you are going to apply behind the pinna, that is on the mastoid process. So it will going to prevent the motion sickness. It is not useful for the treatment. So for morning sickness that occurs during the pregnancy, that is hyperemesis gravidarum, to treat the emesis effect, so you will be using the drugs like doxylamine, which is a potent antihistaminic. Along with that, you will also use the pyridostigmine, that is B6. So next we have a diuretics, which are contraindicated. So diuretic, especially in cerebral edema, you use mannitol. But if there's a cerebral hemorrhage, the mannitol is contraindicated. And diuretic is contraindicated. Which diuretic is contraindicated in case of hepatic encephalopathy? Especially the acetazolamide, because acetazolamide will increase the ammonium levels, because of their alkalinity. Since it creates the alkaline nature, there will be increase in the ammonium levels due to the alkaline nature. They are totally contraindicated. Is that clear? So mannitol is contraindicated with respect to cerebral hemorrhage, not with respect to cerebral edema. Next we'll move on to the next concept, that is, so where do this diuretic will going to act? So diuretic will going to act mainly on these systems. So we have a loop diuretics. So please remember, we have a loop diuretic which acts at the junction where there will be a transporter, that is sodium potassium to chloride. So it is a loop diuretic, loop of Henle. Basically they act on the ascending loop of Henle. Where it will going to block the sodium potassium to chloride transporter. Next we have a thiazide diuretics. So these are the thiazide diuretics which blocks the sodium chloride in the early part of the distal convoluted tubule. And we have a carbonic anhydrase inhibitor. What are the carbonic anhydrase inhibitor? We have acetazolamide. So these are the drugs which are acting as a carbonic anhydrase inhibitor at the which side? On the proximal convoluted tubule. So under potassium sparing, very very important, potassium sparing diuretic, we have two types. One is the aldosterone receptor blockers and the epithelial sodium channel blockers. Basically they are going to act on the collecting duct. So what are the examples? You should remember aldosterone antagonists. You have spironolactone, eplerenone, etc. What about the example for the epithelial sodium channel blockers? Basically you have amiloride and the triamtrin. So basically this drug, this spironolactone, is associated with gynecomastia, and which is not seen with the eplerenone. Mannitol action, where do mannitol will going to act? So please remember, mannitol will going to act at the site of proximal convoluted tubule, majorly on the proximal convoluted tubule. So there are some drugs under diuretic you need to avoid where there is a sulfonamide allergy. So if the patient is allergic to sulfonamide, so what are the diuretics you need to avoid? So diuretics which are contraindicated are the carbonic anhydrase inhibitors, loop diuretics, and thiazides are all this group of drugs, that is the carbonic anhydrase inhibitor, loop diuretics, and the thiazides will have a sulfur group in the drug. So thereby it can contribute to the sulfur allergy. Here is the exception that you need to know. Exception under loop diuretic is the ethacrynic acid is devoid of ethacrynic acid is devoid of it is devoid of sulfur allergy. So which is a thiazide group of drug, very useful in the chronic kidney disease. Please remember, just the name you should remember, it is metolazone. Metolazone is a thiazide diuretic which is preferred in chronic kidney disease. Next, coming to the very very important concept, that is which are the drugs under diuretics which can cause metabolic acidosis, metabolic alkalosis, which can cause hyperchloremic acidosis, etc. Let us find out. So metabolic acidosis, if it is associated with hypokalemia, that is decrease in the potassium, it is mainly due to the carbonic anhydrase inhibitor. If the metabolic acidosis is associated with hyperkalemia, that means increase in potassium. So which diuretics can increase the potassium levels? It is the potassium sparing diuretics. So there are some diuretics which can lead to metabolic acidosis because of the excretion of all the ions, and there will be decrease in potassium. Metabolic alkalosis, please remember, metabolic alkalosis and decrease in the potassium, they are seen with loop and thiazide diuretics, whereas the metabolic acidosis and decrease in the potassium, they are seen with the carbonic anhydrase inhibitor, because carbonic anhydrase inhibitor would remove all the bicarbonate, so thereby the body goes for acidotic process. So which is the drug which will cause the metabolic acidosis associated with the hyperchloremic condition? Again, it is the carbonic anhydrase inhibitor. So very very important concept. Can we add a diuretic, especially the thiazides, with the lithium? So please remember, lithium will behave as a sodium in our body. So what this thiazide will do is, thiazide, although it will decrease the thiazides are the diuretic agent. What will happen? This diuretic agent will remove all the sodium, potassium, etc. through the urine. What will happen to the plasma concentration? Plasma concentration would have been decreased. So the body will send a signal, and since what they will do is, there will be reflex or the feedback mechanism where the body has got lesser sodium, and the body will tries to absorb the sodium content. Since the sodium is lost, so what has to be absorbed now? Since sodium is not there and lithium is behaving as a sodium, so lithium will be getting absorbed in the place of the sodium, and causes lithium toxicity. Instead of sodium getting reabsorbed, instead of the sodium getting absorbed, lithium will be absorbed. So in place of sodium, lithium will come and it will be absorbed. So this combination is avoided. This combination to be avoided. So what are the diuretics which can cause ototoxicity? So as we learned, even aminoglycosides will cause ototoxicity and nephrotoxicity. Already we studied this. So under the diuretic, we have loop diuretics which can cause the ototoxicity. Then we have vancomycin, we have anti-malarial agent, we have cisplatin and erythromycin. You can remember as the seal. So you can remember as ASEL. You seal so that you cannot hear anything because of the toxicity. So A stands for aminoglycosides, C stands for cisplatin, E stands for erythromycin, one more A stands for the anti-malarial agent, L stands for the loop diuretics. And what will happen when you seal? Volume will reduce, right? when you seal the ear, what will happen to the volume? Volume will reduce. So V stands for vancomycin. V stands for vancomycin. So which is the loop, or which is the diuretic which loses the calcium? So it is the loop diuretic that loses the calcium. Loop diuretic that loses the calcium. So diuretic which is used to prevent the renal stones, and where it can be used for adjuvant drug in the form of the supplemental drug to treat osteoporosis is thiazides. So please remember, very important concept. So diuretic which lose calcium, which retain calcium. So which is the diuretic which loses calcium? Loop loses, whereas thiazides will retain. Thiazides will retain. So the stones are more with the loop diuretics. Okay, next coming to the diabetes insipidus. Diabetes insipidus. So we have two types of diabetes insipidus, that is central diabetes insipidus and nephrogenic diabetes insipidus. Central is also called as neurogenic diabetes insipidus. So what is the drug which is preferred for the neurogenic diabetes insipidus? The diabetes insipidus caused by central is desmopressin. Desmopressin, there is a vasopressin analog, V2 analog. Whereas for nephrogenic diabetes insipidus, the drug of choice will be your thiazide diuretics. Thiazide diuretic. Is that clear? Okay. Next, coming to the what is the drug of choice for syndrome of inappropriate ADS secretion? So in case of treatment of syndrome of inappropriate ADS secretion, you're going to make utilize of the receptor antagonist. Which receptor antagonist? That is V2 receptor antagonist. That is especially the tolvaptan. We have tolvaptan, conivaptan, etc. They are also used in the treatment of the autosomal dominant polycystic kidney diseases, and you can also use in the treatment of CHF to correct the hyponatremia. So what is the drug of choice in the treatment of, very importantly asked question. So which is the drug which is drug of choice for lithium induced diabetes insipidus? Lithium induced diabetes insipidus, the drug of choice will be, since the lithium will be acting on the epithelial sodium channels for their absorption. So basically it acts on epithelial sodium channels at the collecting duct. You can block this. How do you can block this? You can block with the help of amiloride, which is a epithelial sodium channel blockers, which is a potassium channel blocker. Next we have a VN selective drug which has been used for the esophageal varices. So which is a V1 selective drug which is used for esophageal varices? That is your terlipressin, which is a V1 analog. So we have one more analog that can be used in esophageal varices, that is related to somatostatin analog. That is octreotide. You should remember, octreotide is the somatostatin analog that can be used for the treatment of esophageal varices. Basically it will going to contract the blood vessels in the esophagus. Next, coming to the cardiovascular system. So one should remember that all the AC inhibitors are prodrug except for captopril and the lisinopril. And among the statins, all are prodrug except for two drugs, simvastatin and lovastatin. And among the ARBs, which is the drug which is having uricosuric action? So you can remember very easily the drug which starts with low. So that is the losartan. That is causes lower uric acid level in the body, and also it lowers the thromboxane activity. It decreases the thromboxane activity. It has got antiplatelet action also. So it has got antiplatelet action as well as it has got uricosuric action. So next we have a ERB, angiotensin receptor blocker, which has got PPAR gamma agonistic activity. So we have telmisartan. Please remember, telmisartan is a drug which has got the anti-diabetic activity also, because the anti-diabetic drug which has got PPAR gamma agonist is the pioglitazone. So telmisartan can be preferred in case of the diabetic individual, so which can take care of the sugar levels. So which is the PPAR alpha agonist that are available in market? We have fibrates which are used for reducing the cholesterol, So which is responsible for the dry cough, which are induced by the ACE inhibitors? So dry cough as well as angioedema. So you can remember dry cough, angioedema are mainly due to the increase in the bradykinin levels as well as the increase in the substance P. To treat this, what you can do is you can go with the corticosteroids initially. To treat the allergic condition, you can go with the antihistaminic, and finally you can give a very basic, very important drug, that is adrenaline. So what happens if there's a dry cough which is induced due to the ACE inhibitor? So enalapril is a ACE inhibitor. So it can produce dry cough, dry brassy cough. What will be done next? So you need to immediately stop and you can start with the ARBs. So with ARBs, the dry cough when compared to ACE inhibitor is more compared to ERBs. This you should keep in mind. So what are the conditions where enalapril or ACE inhibitors are contraindicated? So ACE inhibitor contraindications. They are contraindicated in pregnancy. Why? It can cause renal artery stenosis. It can cause bilateral artery renal stenosis. So if there is a condition of bilateral renal artery stenosis, they are totally contraindicated. If there is a hyperkalemia, since it also lead to hyperkalemic conditions are removed. And if there is a history of angioedema, the enalapril will not be given to such patient. So can we give spironolactone and captopril? So as we discussed, what is the captopril? Captopril is a ACE inhibitor which is going to increase the potassium levels. Again, spironolactone is a potassium sparing diuretics. This is the potassium sparing diuretics, so which can increase the potassium levels. So increased potassium levels will increase the risk of arrhythmia. So the combination is better avoided. And we have one more very important drug, that is aliskiren. So what is aliskiren? So aliskiren is a renin inhibitor. It is a direct renin inhibitor which is used for treatment of hypertension. Next, let us move on to the anti-anginal drugs. So under anti-anginal drug, a very important drug is the nitric oxide. So nitric oxide will going to act to the secondary messenger. What is the secondary messenger? We learned. Basically, please say nitric oxide will going to increase only the cyclic GMP, which is the secondary messenger, not the cyclic AMP. It is cyclic GMP. Especially it causes venodilation when compared to the arteries. Venodilation is more when compared to the arteries. So primarily, what is the aim of nitrates in classical angina? Basically, it will reduce the preload, afterload, etc. So what will happen in case of the variant angina? Basically, it produces the endothelial independent coronary vasodilation. Because why there is a vasodilation? So cyclic GMP will going to increase the nitric oxide production, which will going to act on the vascular endothelia, which relaxes the vascular smooth muscle, leading to vasodilation. At this point, let us also understand one more very, very important thing. In case of variant angina, why beta blockers are contraindicated. Please remember, in the blood vessels, what happens? You have a beta 2 as well as alpha 1. If you block beta 2, what will happen? Already there is a vasoconstriction due to the accumulation of thrombus, etc. So if you give a beta blocker, what happens to the coronary vessels? There will be increased activity of the alpha. This will lead to increased vasoconstriction. So which is bad here. So it can increase the risk of MI. It can precipitate the MI. So you avoid using beta blockers in variant angina, which is also called as vasospastic angina, which is also called as Prince-Metal's angina. Okay, what will the nitrates do to the coronary blood flow? Nitrates will going to increase the total coronary blood flow. So please remember, nitrates will not going to increase the coronary blood flow. Basically, it will going to redistribute. Basically, it will going to cause redistribution of the blood. For example, if this is the ischemic area and this is the non-ischemic area. This is non-ischemic area and this is ischemic area. So whatever the blood going to this blood will be diverted into the ischemic area. That is the redistribution. So what happens if the opposite occurs? Instead of the redistribution, if there is a blood flow to the non-ischemic area, so this is called as coronary steal phenomenon. What is this coronary steal phenomenon? There will be blood shifting towards the non-ischemic area. This kind of phenomenon is seen by dipyridamole. Dipyridamole is the example. Which is an antiplatelet agent which has got coronary steal phenomenon. So which is the a drug that can be given inhalationally to treat the pulmonary hypertension. That is your nitric oxide. Inhaled nitric oxide can be given to treat the pulmonary hypertension. So next is nitrates. Whether nitrates are useful in renal colic? No. Nitrates are not useful in renal colic. They can be used for the esophageal spasm and the biliary spasm. These nitrates will not going to relax the ureter smooth muscles. So that's why they are not useful in the renal colic. So why you need to provide a drug-free interval in case of nitrates? So drug-free interval is provided to prevent the tolerance, to prevent the tolerance. So next question, very important, is can we combine the nitrates and the sildenafil? Not at all. We cannot combine nitrates and sildenafil. The reason being, as you can see here, the nitrates will going to increase the cyclic AMP. What this will cause? There is an increase in nitric oxide, and sildenafil is a drug which is used for erectile dysfunctions. It is a phosphodiesterase 5 inhibitor, which again will going to increase the cyclic AMP, which will increase the nitric oxide. There will be exaggerated fall in blood pressure. Exaggerated fall in blood pressure, that is hypotension will occur, which is not a good idea to combine the nitrates with sildenafil. Can we combine a verapamil with metoprolol in case of angina? Again, no. The big no. Why? The reason being, verapamil is a calcium channel blocker, metoprolol is a beta blocker. What the combined effect is, there will be decrease in the heart rate, decrease in the conduction. They can be AV block. So it is totally contraindicated. So can we give nifedipine? So nifedipine, whether it will cause reflex tachycardia or bradycardia. So it causes reflex tachycardia. This is the true statement. Because it belongs to dihydropyridines. It will cause vasodilation, and it will cause fall in blood pressure. Thereby it will lead to reflex tachycardia. So calcium channel blocker can be used in GERD. Whether it is true? No. Calcium channel blocker cannot be used, as it can exaggerate the gastroesophageal reflex disorders. It can relax the esophageal sphincter, which can lead to retching and all. So anti-anginal drugs that prolong the life expectancy. Please remember, what are the anti-anginal drugs that can prolong the life expectancy? Very important drug, that is the beta blockers. Especially, it will going to have a beneficial effect, such as it will reduce the arrhythmia risk, it will reduce the post-infarct size. So again, in case of the congestive heart failure or hypertension, which is the drug which will going to decrease the mortality, thereby it also decreases the cardiac remodeling. So we have a drugs like, we have a beta blockers, we have ACE inhibitors, we have ARBs, we have spironolactone, etc. So these are some of the drugs which can increase the disease survival, which will going to decrease the mortality, which will increase the life expectancy of the individual. So okay, next coming to the, which is the anti-anginal drugs that acts by inhibiting the late sodium channel. So it is your ranolazine. So what is your nicorandil? Please remember, nicorandil is a potassium channel opener. So these are some of the drugs which can expect in your exams, that what are the other potassium channel openers, like minoxidil is there, diazoxide is there, and the hydralazine. So very important, one of the very important anti-anginal drugs that can cause vision abnormality, it is your ivabradine. So ivabradine is the drug which can cause visual impairment. How to remember? You can see here, IV, impaired vision. Brady stands for bradycardiac drug. It decreases the heart rate, and also it basically by inhibiting the sodium channels, funny sodium channels. So which is the drug which inhibits the PHOX inhibitor, that is trimetazidine. Okay, can we give thrombolytic in thrombolytics are contraindicated in N-stable? So this is a false statement. This is the false statement. So what is the ranolazine mechanism? It inhibits the late sodium channel. So next, coming to the CHF. So beta blockers. So remember, beta blockers are preferred in chronic only. It is preferred in chronic. They're preferred in chronic, but they're totally contraindicated in case of acute, because in acute what will happen? It will depress the cardiac activity. It decreases the heart rate, it blocks the AV conduction, etc. In chronic what happens? Basically it will increases the survival through the adoption, and also it decreases the cardiac remodeling. Okay, what are the inodilators which are used in CHF? So we have a milrinone, we have a amrinone. So what is the calcium sensitizer that are useful in CHF? So we have drugs like levosimendone. And since it ends with mendone, what are the drug which is ending with enton? We have a bosentan, which is used in pulmonary hypertension. So next, which is the antidote for digoxin? Digoxin is used as a only oral drug that is available for the treatment of CHF. So we have a digibind, which is an antibody to the digoxin. Which is the drug of choice for digoxin induced ventricular tachycardia? It is your lignocaine. So drug of choice for digoxin induced supraventricular tachycardia, it is your beta blocker. And the digoxin mechanism of action in heart failure is basically it inhibits which pump? It will inhibit the sodium potassium pump. So what is the digoxin mechanism in the treatment of atrial fibrillation? It will basically have a vagomimetic action, thereby it produces the AV block, AV nodal conduction block. So which is the most specific arrhythmia that is seen with digoxin toxicity? It is your atrial tachycardia with AV block. And the next is which is the only diuretics which decreases the mortality in CHF. So please remember, it is your spironolactone. Spironolactone will going to decrease the disease progression, increase the longevity, and it will going to decrease the cardiac remodeling. Other drugs, as we discussed, we have AC inhibitors, we have the ARN, and we have a beta blockers, and we have a SGLT2 inhibitor like the dapagliflozin, etc. We have neprilysin inhibitors which are used in CHF. They are sacubitril. So which is the antihypertensive agent which is responsible for angioedema? That is your AC inhibitor, because of the substance P as well as the bradykinin. So which antihypertensive is preferred in case of the pregnancy? Which is the first choice? That is your labetalol. Labetalol has got both alpha blocking activity as well as beta blocking activity. So can we use enalapril in pregnancy? So please remember, you cannot use enalapril as it causes the teratogenicity. You cannot use enalapril. So next we have a CNS, that is sedative hypnotics. So please remember benzodiazepines. So what is the difference between the benzodiazepines and the barbiturates? Benzodiazepines usually acts through, please remember, benzodiazepines will usually act through what? Benzodiazepines are GABA facilitatory in nature. These benzodiazepines are GABA facilitatory. So this is the GABA facilitatory. So what you can remember is benzodiazepines are GABA facilitatory, barbiturates are GABA mimetic in action. So basically the benzodiazepines will going to increase the frequency of chloride channel opening, whereas the barbiturates will going to increase the duration of opening. So which is the antidote for the benzodiazepines or Z drugs or the beta carbolin. It is your flumazenil. Please remember, the flumazenil is the antidote of benzodiazepines. How do you treat barbiturates? Barbiturate poisoning, the symptomatic treatment. So please do not confuse. There is one more drug, that is fomepizole. Fomepizole, please remember, fomepizole, it is a aldehyde dehydrogenase inhibitor. Basically, it is used for treatment of alcohol, that is ethynyl glycol as well as the methanol. Ethynyl glycol as well as the methanol. Is that clear? Okay. Then we have a benzodiazepines which are safer in the liver disease. So the example, the mnemonic what you should remember is the lot. We have the examples such as lorazepam, we have oxazepam, we have temazepam. These are very useful, especially in case of chronic alcoholics. Then we have a barbiturates. Whether barbiturates or enzyme inducers? Absolutely, barbiturates or enzyme inducers. How to remember the enzymes inducers? As we have GPRS, cell phone. So G stands for glycofulvin. P stands for phenytoin. R stands for rifampicin, and S stands for smoking, and one more C stands for, you can call it as carbamazepine, chronic alcohol, and your phenobarbital. So all these are the enzyme inducers. So whereas in case of the phenytoin, carbamazepine are the anti-epileptic agent. So these are the enzyme inducers. We have a valproate, which is also a anti-epileptic agent, but this is the enzyme inhibitor. This you should remember. So what do you need to do in case of the barbiturate poisoning? So whereas the benzodiazepine you are using flumazenil, in barbiturate poisoning, since barbiturate is a weakly acidic drug, you need to go for dialysis, or you need to do the urinary alkalization. So the pH will be different. You give sodium bicarbonate and you make it ionized, water soluble, and you make the drug getting excreted through the urine. Next we have a anti-epileptic drugs which can lead to increased frequency of renal stones as the side effects. These are the side effects. So one is the tozo or zoto, that is zoto, topiramate, and the zonisamide. Even anti-epileptics can cause weight loss. We have three drugs. One is zotofel. Why zotofel? He was very thin. It is felbamate. Zotofel. Then we have a blue skin pigmentation. Anti-epileptics which can cause blue skin pigmentation as well as retinal toxicity is your izogabin and retigabin. How to remember this? It is your easy to make a pigmentation. And retinal, you can remember retigabin, retinal toxicity, retigabin. And also this type of bluish discoloration can be seen with the amiodaron also. So with respect to anti-epileptic drug which can lead to dilutional hyponatremia as well as hepatotoxicity, it is your carbamazepine, and this is less seen in case of oxcarbazepine. So what happens? Can you combine carbazepine with valproate? Please remember, both are hepatotoxic in nature. Hepatotoxic in nature. So you never combine carbamazepine with the valproate. Is that clear? Where do you use carbamazepine? It is also preferred for treating trigeminal neuralgia. And next, coming to the before going to the other drugs, let us see for treating any kind of epilepsy, Please remember the drug of choice will be your valproate. Valproate. Exception is what are the exceptions? So let us see here. Exception is partial seizures. You will be using carbamazepine. And for febrile seizures, you will be using diazepam, rectal diazepam. In case of the absence seizures, especially less than 12 years, since it can cause hepatotoxicity, valproate, you can go with ethosuximide. Ethosuximide can be a drug for absence seizure less than 12 years. If the age is not given, the drug of choice will be your valproate in case of the adults. Is that clear? What is the treatment for status epilepticus? Status epilepticus, the drug of choice will be your lorazepam. It is clear? Okay, fine. Next, which is the anti-epileptic drug which is going to cause the decreased visual field? That is your vigabatrin. Vigabatrin is also a drug of choice for infantile spasm associated with tuberous sclerosis. So what are the other drugs which can cause visual field defect? You have a ivabradine. We have pegvisomant, which is a growth hormone antagonist, and we have anti-TB drug ethambutol. Even in case of the angina, you can remember IV impaired vision. Ivabradine, vigabatrin, pegvisomant, you have VI vision impairment, and ethambutol, eye is impaired. We have enzyme inducers. We have phenobarbital, phenytoin, carbamazepine or enzyme inducers, whereas the enzyme inhibitor is the valproate. Very, very important. And which of the anti-epileptic drugs will follow a saturation kinetic? That is your phenytoin. So which is the anti-epileptic which is safer in pregnancy? We have two drugs which starts with L, Lev and Lamo. That is levetiracetam and the Lamo. And which is the vitamin which is given to prevent the neural tube defect? It is folic acid. If the condition is very risk, in case of high risk pregnancies, you will going to use the higher doses, that is the 4000 micrograms, whereas in case of low risk, you will going to use the 400 micrograms of folic acid. So anti-epileptics, you have anti-epileptics as a drug which is used in BPD as an adjuvant. You can use three drugs. One is the valproate, carbamazepine and lamotrigine. So basically, which is the drug of choice for both prophylaxis and the acute mania treatment? That will be your lithium. For the treatment of rapid cyclers in case of bipolar disorders, the drug of choice will be your valproate. Is that clear? Okay. So what will be the maintenance dose, and what will be the therapeutic dose? So dose of maintenance and therapeutics. So the maintenance dose, so what will be the dose you will be using? 0.5 to 0.8. Therapeutic will be from 0.8 to 1.1, or they say 1.2. So 0.8 to 1.2. If the dose exceeds more than 1.5, it leads to the adverse effects. If the dose is more than 4 milligrams, then it is the toxic dose. You'll need to go for dialysis. Is that right? Okay. So what is the carbamazepine induced Stevens-Johnson syndrome? Basically, they are associated with the gene called as HLA-1502. This is the right statement. So usually this will cause Stevens-Johnson syndrome, rashes, etc. Even the lamotrigine, phenytoin are associated with the Stevens-Johnson syndrome. If the rashes or any allergic reactions occurs with respect to the phenytoin, please change or shift over to the valproate. So what is topiramate? Topiramate is an anti-epileptic agent, newer anti-epileptic agent. They are also used in the treatment of migraine prophylaxis, and also they are used for reducing the craving in alcohol and also to treat the obesity. So how to remember? Top comers, you can say. For top comers, they'll be craving. Why craving will be have for top comers? They need to get high marks, so craving for the rank. So here craving for alcohol. So what will happen by sitting to get a rank? They'll become obese. They'll get what? By sitting at the same room, they can get migraine, and some of them will get epilepsy also. So toppers coming. So what will the toppers get? The craving for alcohol, obesity, migraine, epilepsy. So which is the drug of choice for status epilepticus? You have drug of choice is the lorazepam. So if lorazepam is not there, second you can go for diazepam. If it is not controlled, you can go for the next is the phenytoin, that is phenytoin. Next is the phenobarbital, and next is the general anesthetic, that is propofol and midazolam will be the last resort. So how to treat infantile spasm, which is the drug of choice for infantile spasm? Infantile spasm, you give ACTH. Infantile spasm associated with tuberous sclerosis is your vigabatrin. So absence seizure in childhood, if the child age is less than 12 years, so you go for ethosuximab, because valproate will cause hepatotoxicity. To avoid this, you give ethosuximab. So otherwise, all other absence seizure, the drug of choice will be your valproate. In febrile seizure, you can go rectal diazepam. If the option is there, you can go with even the intranasal midazolam. So for all other purpose, the drug of choice for DTCS, myoclonic, Lennox-Gastaut syndrome, Dravet, it is your valproate. Whereas the trigeminal neuralgia plus partial seizures, the drug of choice will be your carbamazepine. So what does carbamazepine will cause? Dilutional hyponatremia. So imiprazine, can we use imipramine in case of the angle closure glaucoma? No, since imiprazine being a tricyclic antidepressant, main action is to block the noradrenaline and serotonin reuptake. Along with it, it also blocks the alpha receptor, muscarinic receptor, and H. If they block the muscarinic receptor on the iris, on the circular muscle fibers, what it causes? It causes mydriasis, dilatation, and it is the contraindication for use in the angle closure glaucoma. So what will happen if there is a TCA overdose? So in TCA overdose, to prevent the toxicity, you're going to administer the sodium bicarbonate. Sodium bicarbonate will going to reduce the risk of arrhythmia as well as the acidosis caused by TCA. Which is a drug of choice for acute anxiety? Acute anxiety, you can use benzodiazepines like midazolam, alprazolam, etc. For acute psychosis, you will use combination of drug, benzodiazepine and antipsychotic. For acute mania, along with this, you will also use the lithium. Lithium is also called as anti-suicidal drug. Delirium tremors are treated with the benzodiazepines or chlordiazepoxide or the anti-epileptic, that is lorazepam and the thiamine. So next, coming to the SSRI, selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitor side effects are, it can lead to side effects such as the insomnia, it can cause decreased sleeping, difficulty in sleeping, it can create anxiety, it can lead to diarrhea and sexual dysfunction. So what about mirtazapine? Mirtazapine, they are used, please remember mirtazapine, they are used in the treatment of depressions which are associated with insomnia. Mirtazapine is an atypical antidepressant. They are the noradrenaline specific serotonin agents. So basically, this will have a additional H1 blocking activity which is responsible for sedation. This is made utilized in the treatment of insomnia, but not with respect to the SSRI. SSRIs are avoided. Why SSRIs are avoided? Because as you saw, SSRIs will cause insomnia as a side effect, so you cannot use it. And we have an antidepressant which produces least sexual dysfunction. So antidepressant which are producing least sexual dysfunction is BM. That is bupropion and mirtazapine. Bupropion and mirtazapine has got lowest level of sexual dysfunction. So all the sexual dysfunction is related to the increase in the serotonin levels, which can lead to increased sexual dysfunctions. So S for S, serotonin, sexual dysfunction. It's seen with the SSRIs, SNRIs and the TCAs. So what about the premature ejaculation approved drug? So it is the SSRI, that is duloxetine, which is approved for the premature ejaculation. And one more drug we have a duloxetine, which is a SNRI. Then we have SNRIs such as, you need to remember, under this SNRIs we have examples like venlafaxine, milnacipran and duloxetine. So what is the drug of choice for neuroleptic malignant syndrome? Please remember, neuroleptic malignant syndrome, the drug of choice will be your dantrolene sodium. So what is the drug of choice for malignant hyperthermia? Again the dantrolene sodium. So ion which is responsible for neuromalignant syndrome is the calcium ions. There will be increase in the calcium ions which will lead to increase in the temperature. Basically what this drug will do, it will going to inhibit the ryanodine receptors, thereby it decreases the calcium levels, which is a drug which is causing the malignant hyperthermia. We have skeletal muscle relaxant as well as the antipsychotic agents like the halothane. We have a general anesthetics like halothane and the succinylcholine. What is the mechanism? Already we know it is inhibits the ryanodine receptors and the sarcoplasmic reticulum. So drug for acute dystonia which is caused by haloperidol, which is a typical antipsychotic agent. So basically since it blocks the D2 receptors, what will happen to the acetylcholine? So basically in the basal ganglion there will be balance between the dopamine and the acetylcholine. So if you inhibit this, what will happen to this? Dopamine acetylcholine activity will increase. So you need to give a centrally acting anticholinergic agent to treat. So what are the centrally acting anticholinergic? We have benzexol, we have promethazine, we have piperidine, we have benztropine. So you can remember it as 3 P's, benztropine. So these are also the same drug to treat which one? Drug induced Parkinsonism. So which are the drugs which can induce Parkinsonism? We have an antipsychotic agent because it blocks the D2 receptors. We have metoclopramide, etc. So again here, can we ask one more question, that in case of the Parkinsonism, will you prefer the metoclopramide or domperidone? Will you prefer domperidone as an antiemetic agent? Please remember, always this is contraindicated because it is centrally acting, it blocks the D2 receptors, and domperidone can be given as antiemetic agent because they're the peripheral D2 blockers, not the central blockers. So which is the antiemetic which is causing the acute dystonia? That is what? Because it blocks the D2 receptor, especially in the central nervous system, because it crosses the blood-brain barrier. So which is the antipsychotic which is responsible for agranulocytosis? Very, very important. Agranulocytosis, we have a clozapine, which is atypical antipsychotic agent. Along with the agranulocytosis, it can cause the seizures, siluria, increase in the salivation secretion, myocarditis. And also remember that this is the drug which is been preferred in case of resistant schizophrenia. So which is the other antithyroid drug which is responsible for agranulocytosis? Again, it sits with C only. Here the clozapine, you have a carbamazole. So which are the drugs which are regarded as anti-suicidal drug? One is the lithium, that is the lithium is anti-suicidal drug, and the clozapine, they decrease the tendency of suicide. So which is the antipsychotic drug which is responsible for metabolic syndrome? So when you see the metabolic syndromes are seen, they are more with the atypical compared to the typical ones. So under the atypical, you have olanzapine is more metabolic. So what is metabolic syndrome means? Metabolic syndrome is characterized, they can give a case like it is characterized by hypercholesterolemia, and they can have obesity, and they can have insulin resistance. So next, coming to the what is risperidone. Risperidone is also a antipsychotic. They are approved for the treatment of schizophrenia. We have the maniac conditions, bipolar disorders, and in the autistic disorders, hyperactive autistic disorders. So what will happen? The main reason adverse effects of risperidone is it will going to cause hyperprolactinemia. More hyperprolactinemia risk are more with risperidone, and also it increase the risk of extrapyramidal side effect. One more thing at this point you should remember is when compared to the extrapyramidal side effects will be more with typical when compared to the atypical antipsychotics. Usually the typical will involve the extrapyramidal side effects, as well as it causes hyperprolactinemia. As it blocks the D2 receptor, there will be loss of control over the prolactin secretion. So allopurinol, there is an increased EPS due to the D2 blockade. Lurasidone, no EPS because of atypical antipsychotic. It blocks the 5-HT2 receptors. So usually the atypical will block the 5-HT2 receptor, but they will also have weak D2 blocking action. Along with that, they will block alpha receptors, muscarinic receptors, histamine receptors, etc. So which drug is responsible for Epstein anomaly? That is the lithium if it is taken during pregnancy by mother. So what are the other conditions where lithium toxicity is increased? In case of dehydration, in case of hyponatremia, in case of fasting and diarrhea, because of the fluid loss, instead of the sodium being absorbed, the body senses the lithium as a sodium. They have a similar compound. So that's why the lithium will get absorbed and it causes lithium toxicity. So the TDM for lithium is done after 5 to 10 days, and blood will be drawn after 10 to 12 post dose. So morphine, whenever you give a morphine opioid group of drug, they are given to relieve the pain as well as to relieve the pulmonary edema. They are contraindicated in case of biliary colic, head injury, and bronchial asthma, as it calls bronchoconstriction. So what about the pethidine? So pethidine, they are used in case of biliary colic. They do not have such contraindication as it relieves the biliary spasm. Pentazocine, they have three actions. One is mu antagonistic action, mu partial agonistic action, and kappa agonistic action. So drug that will decrease the relapse in case of opioid addicts, you use the naltrexone, which is the opioid receptor antagonist. So morphine can cause respiratory depression, is the most common cause of death due to the carbon dioxide retention. So what is the antidote for opioid overdose? The antidote will be your IV naloxone. So whenever there is a opioid toxicity, you give naloxone. Is it clear? Okay. If opioid causing the inhibition of noradrenaline, inhibition of serotonin reuptake, or they are seen with the tramadol, tapentadol, and methadone. So what is the drug of choice for restless leg syndrome? It is your gabapentin. If gabapentin is not given, you can go with the one of the anti-Parkinsonian drug, that is the ropinirole. We have pramipixole and rotigotine. And what happens to the neurotransmitter in case of diseases like Alzheimer's disease? There will be decrease in the acetylcholinergic activity. Parkinson's disease, there will decrease in the dopaminergic activity. So which is the most effective drug for smoking cessation? It is varenicline. So hypoglycemia and anti-diabetes. So hypoglycemia are associated with more commonly with the insulin sulfonylureas like glipizide, glimepiride, etc., and meglitide. Example is netaglitide. So the risk of urinary tract infection was maximum with which antidiabetic drug? The drug which are blocking the SGLT2 inhibitors in the renal system. Thereby it decreases the absorption of the glucose. That is the empagliflozin, which are most commonly risk for genital mycotic infection, that is the fungal infections. We have antidiabetic drugs with respect to weight loss, weight gain, and the neutral weight. So dapagliflozin, which is the GLP-1 agonist, as well as the pramelinide will going to cause weight loss, whereas the weight gain is seen with the insulin, sulfonylureas, meglitinides, and pioglitazone, and weight neutral is seen with the metformin and the DPP-4 inhibitors. What is the non-diabetic use of metformin? Non-diabetic use of metformin, they are used in the treatment of polycystic ovarian disorder. So what is octreotide? Octreotide is a somatostatin analog. Basically, they are used in the treatment of the secretory diarrheas, acromegaly, insulinoma, and glucagonoma. They are also used in the treatment of esophageal varices. The other drug which is used to esophageal varices is the V1 agonist, that is the terlipressin, which is a vasopressin analog. Next, coming to the which is the longest acting phosphodiesterase inhibitor. So longest acting phosphodiesterase 5 inhibitor which is used for erectile dysfunction is tadalafil. Like sildenafil, we have sildenafil, tadalafil, etc. Tadalafil is the longest action. So we should never combine with nitric oxide. Please never combine with nitric oxide. It decreases the blood pressure. Which is the longest acting ARBs? We have a TOL, that is telmisartan is the longest acting ARBs, and also it is a PPAR gamma agonistic activity, thereby it decreases the blood glucose levels. Which is the SCRM that is used for treatment of breast carcinoma. So we have a tamoxifen which is used to treat breast carcinoma. One of the risks is it has got agonistic activity on the endometrium, which will going to increase the risk of endometrial carcinomas. Which is the SCRM, selective estrogen receptor modulator, which are useful in the treatment of osteoporosis. We have a raloxifene. Raloxifene is the SCRM which is preferred for osteoporosis. So SCRD, selective estrogen receptor downregulator, used in breast cancer, that is fulvestrant. So what are the example for aromatase inhibitor? We have a exmestine, formastine, letrozole, and the anastrozole. Which are the drug which are preferred in case of drug that is used in the treatment of hyperprolactinemia, which is also responsible for infertility. So we use the dopamine agonist like the bromocriptine and cabergoline. Please remember, recently the bromocriptine has also been tried in the treatment of diabetes mellitus. So sildenafil and nitrates are contraindicated. The reason being it causes decrease in the blood pressure because of they both increases the cyclic AMP, therefore increase nitric oxide, decrease in the blood pressure. So aplasia cutis congenita, they are seen with whenever the mother takes a carbimazole, metamazole, which are the anti-thyroid drugs. Drug of choice for hyperthyroidism in pregnancy is your propylthiouracil, which does not cross the placental barrier. What are the GLP-1 agonists which are used for obesity? We have two drugs which I already discussed. That is the liraglutide and the semaglutide. Liraglutide and semaglutide, they are also used as anti-diabetic drugs. Which are the GLP-2 agonists that are used for short bowel syndrome? That is the teduglutide. Remember, this is the DPP-4 inhibitors. In case of DPP-4 inhibitors, which is the drug where it does not require a dose reduction in case of the renal failure? It is your linagliptin. Linagliptin is the DPP-4 inhibitor which does not require a dose reduction in case of renal failure. And to treat the premature delivery, to increase the lung maturation, to improve the lung maturation, what you can give is the dexamethasone. If dexamethasone is not available, you can go for betamethasone. Drug which can promote the bone formation is teriparatide, which is a recombinant parathyroid hormone. Which is the drug of choice for osteoporosis? It is your bisphosphonates. And next, there are some more drugs we need to remember, which is the toxic metabolite of paracetamol. It is your N-acetyl para-amino-benzoquinine amine, which is the antidote for paracetamol poisoning. It is your N-acetyl cysteine. And one more thing you should remember is which is the drug which is used for the drug of choice for acute migraine, the drug of choice will be your sumatriptan, which is a 5-HT 1B 1D agonist, 1B 1D agonist, which is the drug preferred for prophylaxis of migraine. You can use propranolol, which is also used for treating the performance anxiety. Is that clear? Performance anxiety, which is the drug which is used to treat the NSAIDs induced peptic ulcer, or it can be written as smoking induced peptic ulcer. It is your prostaglandin E1 analog, that is misoprostol. It is your misoprostol can be used here, misoprostol. Then there are some of the drugs you should remember, which is the antidote for the heparin overdose. You give protamine sulfate. For the warfarin overdose, you give vitamin K supplementation. So which is the route of administration of low molecular weight heparin? It is through subcutaneous route, and it does not require monitoring. Is that clear? And how does this what are some uricosuric agents? Uricosuric agents, we have probenecid, sulfenpyrazone, and benzbromazole. Which is the fastest acting anti inflammatory agent that is used in gout? So colchicine is the fastest acting drug to decrease the pain. It is basically, it inhibits the chemotactic neutrophil chemotactic activity. What about the allopurinol? Allopurinol is a drug of choice for the treatment of chronic gout. Allopurinol, which is a xanthine oxidase inhibitor. There's one more drug called as febuxostat. This is the purine derivative. This is the non-purine derivative. Again, it blocks the xanthine oxidase inhibitor. We have some other drugs which can increase the uric acid secretion by the uricase activity. We have pegloticase, and we have pegloticase, and we have rasburicase. So next we have a rheumatoid arthritis. The drug of choice in case of rheumatoid arthritis is your methotrexate. What is anakinra? It is a interleukin 1 receptor antagonist. Interleukin receptor 1 antagonist. Whenever you give a methotrexate, you need to supplement with the folinic acid, which is also called as citrovorum factor, etc. And also one should remember that in case of treating gout, in gout patient, can we give aspirin? Aspirin is avoided because it causes hyperuricemia at therapeutic doses. If the aspirin is given in children's less than 12 years of age, what is the syndrome which is associated? Especially if the children is associated with viral fever, it will lead to race syndrome. So it will lead to race syndrome. Race syndrome means it will have hepatoencephalopathy. Hepatoencephalopathy. It will have hepatoencephalopathy. Then we have a drugs like ergotamine. So why ergotamine is not preferred? Main side effect, ergotamine, they are basically used in treatment of migraine and also for induction of labor. Basic side effect is it causes the nausea and vomiting. That's why in migraine you use sumatriptan. And also you should remember that both sumatriptan and these ergotamine, they are contraindicated in case of ischemic heart disease patient, in case of hypertensive patient, etc., because it will going to cause vasoconstriction. So in migraine there will be vasodilation which produces the pain, and these drugs will going to cause vasoconstriction. You should be very, very careful when you are giving this group of drugs. And apart from that, what you should remember is there are certain drugs with respect to the antihistamines. So antihistaminics, we have first generation and the second generation. So first generation will cause sedation, second generation or less. Reason being, it crosses the blood-brain barrier. It causes blood-brain barrier. Is that clear? And to treat the physostigmine overdose, which is the drug which is preferred, you use atropine. Atropine is a drug of choice. For treating the atropine overdose, you use physostigmine. So which among this drug will cause floppy baby syndrome? So especially the antipsychotic drug, that is lithium, will cause floppy baby syndrome if it is not stopped 24 to 48 hours before delivery. It will going to cause hypotonia. So in case of extrapyramidal side effects, which is the earliest to appear and which is the late to appear? Earliest to appear is acute dystonia and late to appear is tardive dyskinesia. Very, very important. So these are some of the very important high-yield pharmacology topics you need to understand, and please go through it, and definitely it will help you in terms of analyzing the questions and opting out the right answers. Though it looks difficult, with constant effort each day, you'll be able to overcome all your fears with respect to the pharmacology. Hope this have helped you in terms of the pharmacology revision for FMG examination. If you have any doubts, you can put it in the chat box or the comment box. So apart from this very important thing, last topic let us discuss regarding which is the system which is used for analyzing the adverse drug reactions. It is your pharmacovigilance which deals with the three mainly DAUP: detection, assessment, understanding and prevention of the adverse drug reactions. So usually pharmacovigilance will deals with the which phase of the clinical trial? It deals with the phase 4 of the clinical trial. So what are the clinical trials? You know, clinical trials clinical trials. So we have phase 0, we have phase 1, we have phase 2, we have phase 3, we have phase 4, and we have phase 5 also. Phase 0 is called as micro dosing study. So you'll choose 1/10th the dose, and only 1 to 10 healthy volunteers will be there, and just you will going to check for pharmacokinetic parameter. If pharmacokinetic parameter is showing any optimal response, you can go with phase 1. Otherwise you will going to stop there. So phase 1 is nothing but safety. It is a dose exploratory study where you will be choosing the 10 to 15 healthy volunteers, or sometimes they will give 10 to 20 healthy volunteers. And what will you do in phase 1? Phase 1 is done in healthy volunteers. Basically you are going to check the maximal tolerable dose, and you will going to check for the safety. These are two things you will going to do. In case of phase 2, that is the therapeutic, they are called as therapeutic confirmatory study. This is the human confirmatory study where you will going to choose the patients. It will be from 100 to 500. So this will be the single center. Basically you are going to confirm the efficacy here, as well as the adverse effects, etc. So whereas in case of the phase 3, which is also called as sometimes again in the larger context, what you will do is again you will going to take the patients here. It will be of 500 to 5000. Again you will check this in the multi-centric, and again you will going to check for the efficacy confirmation. Phase 4 will be your pharmacovigilance. It will be done in the population. It will be done in the whole population. Phase 5 is called as pharmacoepidemiological study based on the human response. So in this question, what they will ask is again, so where do you apply for investigational new drug and the new drug application. So investigational new drug is applied just before the if they give just before the phase 1, Where do you apply NDA, new drug application? New drug application is applied before NDA is applied before the phase 4, clinical trial. Is that clear? So this concept can be asked. Many times they have asked when to apply for investigational new drug, that is before phase 1, and new drug application, it is before phase 4. Is that clear? Okay, fine. So these things you should remember. And hope we'll end the discussion here. We'll come out with the other important high-yielding topic in the next class. Have a nice day. Thank you.